السلام عليكم ورحمة الله وبركاته. نكمل حلقات أو فيديوهات الكدني ترانسبلانت بيزك كلينيكال بيرلز. إن شاء الله اليوم هنتكلم لو أنت مناوب أو on call for kidney transplant service or department. When you called for disease or DCD or DCC, exception distribution kidney donor with negative NATs, and withdrawal, it will be like 2100 on pump, and the KDPI 77% kidney donor. And we'll come to this already. And you should, from this donor after cardiac death, the exception distribution, and the KDPI around 80% or whatever, just you should expect this will be like, and donor age, for example, above 60s, and this considered as ECD kidney extended criteria donor with delayed graft function likely to be with any patient with deceased donor after cardiac arrest, because long ischemia time, as I told you before, waiting for withdrawal of life support and waiting to take the kidney as a last organ from the body of the donor. And we just usually doing stat cross match. Stat cross match, this means flow cross match between the blood, not virtual cross match. It's a flow cross match, blood of the donor and the blood of the recipient. Now, you should see and decide what is the type of induction and CNI dose you think we should use for this patient. Suitable guess when you have kidney donor. While you are on call, you should look for the creatinine of this donor, ultrasound of this donor, and CT scan for this donor kidneys, albumin creatinine ratio, and renal biopsy really used to determine suitability, but usually we are doing implantation biopsy for any kidney transplanted for any of our recipient. Implantation biopsy to give you baseline, what is this kidney? At least if you have severe retain, severe fibrosis, degree of fibrosis, acute tubular injury, it will be suitable at the baseline for your recipient for future if he's more delayed graft function. Delayed graft function, just will come to this in details. It means the patient need dialysis during the first week after transplant, either peritoneal dialysis or hemodialysis until the kidney recover from the severe acute tubular injury from prolonged ischemia time, either cold or warm, and we'll come to this later. And for quality of the deceased donor kidney, usually we are looking for the donor age to decide this patient standard criteria or extended criteria donor, as we discussed in the previous talk. And this patient DCD or DNC or after cardiac death or after brain death, any history of diabetes, prolonged hypertension, cardiovascular disease. If my patient elderly and DCC with multiple comorbidity, maybe I will have authority to decline this kidney for my recipient if he's a young recipient, and will give him this kidney with multiple atherosclerotic blood vessels or whatever complication. Maybe it will work or not work with him with a lot of complication. Better to decline and wait for another good kidney. Cause of death as a trauma versus anorexia is different already for the viability of the kidney tissue infection. Some infection need transplant ID like hepatitis C or HIV. We are not accepting HIV except for HIV positive donor. Imaging available, just look for CT and chest X-ray or whatever to be sure no malignancy, no infection, no active ongoing issue for this donor. And urine for urine ECR is most important if this patient with heavy proteinuria, just maybe will decline this also. And first creatinine, previous creatinine, and terminal creatinine. What is this creatinine at the start, and what is previous one? What is the last creatinine for the donor to decide to accept this donor or no? KDPIs is like calculation. If you'll go to Google and search for these two terms, you will see this KDPI usually is measuring from 0 to 100%. Lower KDPI is a better quality of kidney, and the higher KDPI means poor quality kidney, is more like marginal kidney already. This depends on the age of the donor and height, weight, ethnicity, hypertension, diabetes, this. Cause of this also, DCC will make this KDPIs too high. Serum creatinine, hepatitis C, and donation after cardiac death, as I told you, all this will make KDPIs high. If the KDP is high, around 80-90% will be not good kidneys, or as a quality is not good kidney. And if it's low KDPI, like 10%, 20%, 30%, will be better kidney. And this just shows the donor age and the KDPI. Once the donor age is also, with increase the donor age, it will increase your KDPI also. But maybe sometimes it's good kidney, and we accept this kidney for our donors. And the difference between 1 year and 2 years graft survival rate with KDPI, lower KDPI is better than the higher KDPI. And this only, you lose only this and thinking the deceased donor. Some center just calculate this KDPI, but if you find the kidney is good with normal kidney function, no multiple comorbidities, and the patient just we are proceeding, and most of the times the kidney is working well without any concerning already. You be informed to call while if you are responsible, you are either consultant or staff or resident or whatever, or fellow on call. You are responsible to call the recipient. You will be informed about the data from the donor, from your staff. Once you confirm the patient is coming, you should inform your surgical team. and also you just should examine your patient and do routine blood work once the patient here. Maybe you repeat chest X-ray, ECG, and see what is your surgical or transplant team recommendation for your patient. Before you are calling in a recipient for diseased kidney or in a recipient in general, you should confirm this your recipient didn't have any fever or recent infection or other illness before at least the last week or the last month, or no new antibiotic, no new medications, and the new cardiac or anginal symptoms, especially if you're a patient, you have high cardiovascular risk patient, and time from last dialysis, especially hemodialysis, because usually we prefer to dialyze your patient before the surgery at night of surgery, or better to dialyze before the surgery as possible. And better to know what is the residual kidney function, how much urine output your recipient putting or making before the kidney transplant. At least will guide you after transplant. Is this from his native kidneys or from the new transplanted donor kidneys? And recent plant transfusion, this will make you a little bit cautious and alert for stat cross match between the donor and the recipient, and review the patient with your team and determine if your patient need dialysis or no. You will arrange dialysis, especially with potassium around 5, and just keeping your eyes to keep your patient weight 0.5 to 1 kilogram above his dry weight or target weight. No heparin in your dialysis order for any patient going for kidney transplant surgery. Sometimes we are using heparin. If I will dialyze him today and his surgery tomorrow, maybe we'll give just a regular heparin. It will be end after 6 hours already if you have history of fistula clot or blood clots. Your patient in peritoneal dialysis, I will arrange the same cycle all night. Maybe we'll give him 8 hours, 9 hours, whatever, and be sure he will be drained at morning before his surgery time. طبعا أول ما once the patient arrives to his bed on hospital, you should confirm again any recent infection, hospitalization, surgery, illness, blood transfusion, all this as we mentioned before. You inform it from the phone and you confirm again with the patient, focusing on physical examination. Any skin ulcer, you should look for his foot, especially for his feet, especially if patient with diabetes and history of peripheral vascular disease. Just examine your patient from head to toes. Sometimes in his head, you will find some abnormal lesion in his skin hairs, or just check his back, front, groin area, because sometimes hidden infection. You should be sure this patient not hiding any ulcer or infection before sending him for kidney transplant surgery. And to confirm dialysis as mentioned, and the peritoneal dialysis, and we mention all this. If you feel patient is not good candidate, call the attending and discuss to check for another recipient or delay his surgery. After surgery, you should see the patient in recovery room to be sure your patient vital is stable and the GCS is stable and his urine output is making urine or no. And if check how much is fluid given by the anesthesia, how much blood loss, surgical or transplant surgery, notes for how many arteries, how many vein, any reconstruction. Put in your mind any vascular anastomosis or reconstruction during the surgery. Keep in your mind this patient maybe will need just anticoagulation or aspirin as antiplatelet, because the patient is risky for thrombosis or clotting of these blood vessels. Keep this in your mind to look for the surgical note, how many blood transfusion, any blood loss, how many liter fluid given during the surgery. And how much warm ischemia time after taking the kidney from a box of ice or pumping machine until declamping and the blood perfusion to the kidney. And you should send all basic blood work, especially serum electrolytes, especially for potassium, calcium, whatever, and do ECG as needed, and troponin as risk of your patient for cardiovascular after surgery. Early post-transplant issues, you have delayed graft function, especially with high potassium, and delayed recovery of the kidney, no urine output, and the patient, sometimes you will deal with him medically but no respond. But if patient came potassium 6 after surgery, you should arrange dialysis for him, and should be like gentle dialysis, decrease the blood pump, no heparin, no fluid removal, just you are dialyzing to remove the potassium and some uremic toxins. Otherwise, no need to remove any fluid if despite your patient not overloaded. And we have also donor infection. You should remember your donor details if your patient needs to continue antibiotic or screening after, especially for hepatitis B, C, and HIV. You should look for urine and wound care, especially patient with prostate and obesity. Sometimes obesity for wound care delay wound healing. And urine, sometimes with prostatic hyperplasia, need longer Foley catheter embolization. Should be from day one. Your patient should out of the bed. This enhanced recovery after surgery, ERAS protocol, and nutrition. Just try this already retroperitoneal surgery. Just try clear fluids and full fluid and regular diet by day one. And if you, especially you'll be more comfortable if your patient passing gas. And for lung atelectasis, just incentive spirometry. Just from day one, you should encourage your patient to use this one, and you should put clear order for this to avoid any atelectasis or respiratory tract infection. And urine tract infection, just check for all the culture reports and send the urine culture if you suspect any burning urine or fever or whatever. Just you'll send all septic screen already. Acute rejection, PRA or DSA, close match, immunosuppression exposure, serum creatinine rising. If you suspect, you should rule out this already. But it's too early to see this, especially during the first week of transplants. Therapeutic drug monitoring, tacrolimus level or sirolimus or mycophenolate, but usually we are looking for tacrolimus level post-operative day 1. Proteinuria, urine dipstick, ACR, especially if your patient like focal segmental glomerulosclerosis or aggressive course of his interstitial disease from primary glomerulonephritis, we should screen for in urine in his protein. Sudden drop in urine post-transplant, just check your folic acid flushing by the transplant surgeon. If you're obstructed by any collection outside, and no blood flow to the kidney by ultrasound, hyperacute rejection, this will, I think this not, I don't see this long time ago because there's a good technique now for cross-matching and blood compatibility already. And what's your action if you will see your folic acid, no urine, and no blood flow to the kidney? But just for this, you should just do flush for your folic acid, your patient folic acid by saline to just to remove or dissolve any clots. Urgent Doppler ultrasound should be done. If you see any one of the above urgent ultrasound Doppler, this is number 1. And call transplant surgeon if you see any surgical complication. For discharge your patient after transplant, he should be able to avoid or urinate spontaneously without any problem or straining or retention. Your patient should be ambulating and eating normally. Your patient educated well for his medication, adequate home support, including reliable transportation to clinic, and for dialysis catheter, because sometimes we are keeping dialysis catheter and the kidney will normalize. Maybe you're removed after 1 month, 2 months, 3 months, whatever. We need to be sure the dialysis looked well and clean exercise and care for the dialysis catheter frequently until it will be removed. Wound care if needed, and prescription for any all his transplant medication already covering at least 1 to 2 months, and the clinic appointment and the clinic orientation, how the patient will arrive to the clinic, and clear schedule for his next clinic appointment, and discharge summary by all details for all your patients from A to Z. This is the donor summary for this. This is donor transplant. It is associated with excellent patient graft survival. We have this, sometimes we see donation after brain death, and some cases from donation after cardiac death, it looks like sometimes better than the living kidney. Understanding the physiology changes associated with brain stem death and the cardiac death are essential for success of your program. Criteria for living donor or live donor. When you will accept a live donor, it should be normal kidney function, symmetrical renal function by renogram or nuclear scan, no proteinuria, normotensive or mild, easily controlled hypertension or 2 medication, no diabetes, no history of other significant disease, competent to give informed consent, and unpaid and commercial. Commercial kidney should be avoided. For this criteria, you can accept any live kidney donor. and safety as regard the live donation. And we can see the detached line here, the matched control, and this is a live kidney as regard the mortality and years after donation. All this study to be in summary safety for live donation, they found the live kidney no big difference between the control, the people not donate the kidney, but in the reverse. بالعكس يعني طبعا المرضى اللي هم بيتبرعوا بالكدني طبعا بيبقوا more careful for his kidney and more screening other than the patient don't donate any kidney. He's just neglected his kidney until he will discover is have some kidney related issue, and they here show this little bit risk for blood pressure with longer time, rare to see this deterioration of his kidney function for the kidney donor. At the end, the kidney donation, it will not affect the survival or the remaining kidney function of the donating donor, the kidney donor. But the reverse, the patient, the comparison by control groups, or patient don't donate the kidney. The patient didn't do any routine screening for the kidney function, not taking care of the kidney. In comparison by the donor donates the kidney, he's more careful, more aware how to protect the kidney function. And also put in your mind, any kidney donor, the remaining kidney will compensate around 70 to 80% of because some hypertrophy of the remaining kidney for the kidney donor, and it will make his like kidney function or CMTG far nearby the normal, and not affect his whatever kidney function in future, and he's doing well, and we don't see any kidney donor with any complication all over our experience or in kidney transplant in here in Toronto or any other area. It's rare to see donors suffering from end-stage renal disease except if strong family history or missed or unclear or non-honest pre-transplant workup for the donor. We should screen our donor for any future especially genetic or strong family history of kidney disease. ونكتفي بهذا القدر في هذا الفيديو، ونلتقي إن شاء الله بفيديو قريب بإذن الله لتكملة الكدني ترانسبلانت بيزك كلينيكال بيرلز. والسلام عليكم ورحمة الله وبركاته.